Dear colleagues, this is a case of phacolytic glaucoma. The patient came with redness, pain and high intraocular pressure. The intraocular pressure was 60. We admitted the case. We gave intravenous mannitol and other anti-glaucoma medications, and the pressure came down to 40 millimeter of mercury, and then we took this case for surgery. By this time, all the incisions, the main incision and 2 side port incisions have been made. A big air bubble is injected into the antechamber, and trypan blue dye is sprayed over the anterior surface of the cataractous lens to stain the anterior capsule of the lens. Here it is. This is trypan blue dye. It is sprayed over the anterior surface of the cataractous lens. The dye is washed out with a direct Simcoe cannula, and the white fluffy material that settled towards 6 o'clock is also removed. The angle must be cleaned thoroughly, and all the material that leaks from the lens through the intact capsule must be washed out. Now, viscoelastic substance. I have only 2% HPMC is injected into the antechamber, and it is sprayed over the surface of the cornea with the over the epithelial surface of the cornea for better visualization. Now a very sharp 26 gauge disposable bent cystitome is used to incise the capsule. Aorta forceps is taken, and very gently capsulorhexis of optimum size is done at the first attempt, because in such cases the intralenticular pressure is not high, unlike intumescent cataracts. The milky fluid is there, but the intralenticular pressure is not high. But we must be very careful while we do rhexis with utreta or needle. We must be very careful because the zonule can be weak, and we must not cause any stress over the zonule. Now the milky fluid has been aspirated, and we can see that it's a free floating cataract. I want to emulsify and remove this cataract without using any other viscoelastic substance except 2% HPMC. Let us see if it can be done. This is the easy tip of Oatley's phaco machine. I go bevel down so that there is immediate and firm occlusion of the tip, and I can have a very firm grip of the nucleus. I could make a crack at the equator. I rotate the nucleus 180 degree, and I make another crack here. But the nucleus does not divide into 2 heminuclei. I try to crack it here and there. Now, if it doesn't crack, then what to do? I have to apply another technique that is called the lens tilt technique. In this technique, I tilt the lens so that one equator goes towards the posterior capsule and I work on the opposite equator. Just like a rat munches on a piece of bread, I am just trying to munch it off, thinking of in that line. Here I start, and I can make a small fragment free, and then I work on the center of the cataract. See, the other equator, which is towards the posterior capsule, is actually protecting the posterior capsule. So this free floating nucleus is acting like another instrument which is protecting the posterior capsule. The chopper is guiding one side to the phaco-tip, the other side is protecting the posterior capsule. So I have been able to crack the nucleus, and this is the last fragment. I remove the chopper so that there is no leak from the side port. The chamber becomes deeper. The posterior capsule goes backward posteriorly towards the vitreous. The chamber becomes more stable, and I can confidently emulsify the last bit of nucleus. Here it is. During this time, the phaco power was 70%, flow rate was 45, and vacuum was 450. We can see some cortical matter superiorly from 11 o'clock to 2 o'clock. The rest of the equator of the capsular bag is free. There is no cortical matter. In this case, I am going to use bimanual irrigation and aspiration to clean the cortical matter which is there from 11 o'clock to 2 o'clock. So it is possible to do all cases using hydroxypropyl methyl cellulose. And in all of my cases, the cornea remains clear on the first postoperative day. I become more gentle, more cautious when the situation is tough. Viscoelastic substance is used to inflate the capsular bag, and a hydrophobic acrylic intraocular lens is implanted in the capsular bag. So the conclusion is, it is possible to emulsify a free floating lens in phacolytic glaucoma using only viscoelastic substance, using only 2% HPMC. We just have to tilt the lens, make one equator of the free floating nucleus, protect the posterior capsule, and work on the other equator, emulsify the other equator, and that's it. In no time, in about 2-3 minutes, the whole nucleus is emulsified and it is taken out. Chamber must be very stable. We should not give any stress on the zonule, and that's it. In this case, after implanting the IOL, the viscoelastic substance is cleaned nicely, the side ports are hydrated, and a chamber is formed, and that's it. Thank you very much for watching.